Hello everyone, how are you all?
Hope you are all doing good. And let's start the fifth question.
Which of the following is true regarding pediatric cardiopulmonary resuscitation? Now, this should be very easy for you. Let's see. First option, the chest compression at a rate of 30:2 with two rescuers. Okay, you have to remember that when there are two rescuers, we will give a we will exchange very rapidly. That means if the two persons are there to give a CPR, first person will give just a 15:2. Okay. So if only one person is there to give us resuscitation, that time we don't have anyone else to do, right? So single person will give 30:2. So here with one rescuer, it was a two rescuer, that should be 15:2. Okay. So first option is wrong. Adenosine via intraosseous route is preferred over other methods. Why adenosine is used in CPR? No. Adenosine is used in adenosine for PSVT. What is PSVT? Paroxysmal supraventricular tachycardia. How I remember adenosine has? Yes, right. So PSVT also has yes. So adenosine for PSVT. Okay. In chest compression, the depth must be at least 1/3 of the child's chest AP diameter. Yes, this we have seen in our previous questions also. Correct. The adrenal is given in a dose of 0.01 mg per kg IV or intraosseous route IO in 1:1000 concentration. In children, we will use epinephrine, not adrenaline. Okay, let me show you the explanation. See, epinephrine is a drug of choice for treating the bradycardia in
ml per
infants and
kg.
children. The recommended dose is 0.01 of 1:10,000 solution. In question they have given 1:1000 and they have given adrenaline, not epinephrine. So this is fourth option is also wrong. Okay. See, when there is two rescuers, you have to give 15:2. When there is one rescuer, 30:2, similar to adult CPR. Adenosine is used in PSVT. Okay. This thing we have already discussed. So I'll stress only on this option. The depth of compression is 1.5 inches. They have not given 1.5 inches. They have given 1/3 of the depth of infant's chest. That is AP diameter. Two fingers, one between the nipple and other just 1 centimeter below the nipple. This is when one provider is present. Whereas two thumb technique is used when there are two providers are present. Okay. In children older than 1 year up to puberty, you can just compress with one hand also, or both the arms also can be used like adults. Hence, only this option is correct. See, if you have not known any of the option, if you have known only this option is correct, then it will be easy, right? Yes. Sixth question. The Jackson-Rees circuit is used in. Yes. Jackson. Son is a adult or a pediatric? Yes, son is a pediatric. So it is used in pediatric anesthesia. So you have to remember Jackson-Rees. Coming to the Jackson-Rees circuit is used in pediatric anesthesia. It is nothing but the modified arrest T piece is classified as Mapleson F system, that is semi-closed circuit. You can see here it is a Mapleson F circuit. It is has only one opening. Okay, this is the semi-closed. Here FG is fresh gas will come. This is the patient end. Okay. Here you have to know this A and D are very important. Okay. What is A? that is Magill's circuit. A is Magill's circuit. This is spontaneous ventilation. Here patient wind will be there. Here the fresh air will come. And this is one end. This is the spontaneous ventilation. This B and C is not used now, so no need to worry. Whereas D is the Bain circuit, it is very much used. Okay, here there is controlled ventilation and most common used circuit. See, how I remember is like both are at the same level, right? So you can control it. But see, this side, one is coming from this side, another one is this side. So you can't control this. So this is spontaneous breathing. Whereas when both the pipelines are in the same level, it's a controlled ventilation. See, this is just to remember I am telling. Okay, is nothing like this explanation. No one will give you, no anesthesiologist will give this type of explanation. But just ultimately, what is most important is how much do you remember. So I am telling all these stuffs, but just remember both the side, both the ends are in same level, then it is controlled. You can control it. Okay. Whereas E is the arrest T piece. Okay. Jackson Reese is the modified of this arrest T piece. See, here is same. This much is same, but here again one balloon light. Okay. This arrest T piece is the second choice for children, whereas Jackson Reese is first choice. Okay. I feel you have seen in the anesthesia posting that Bain circuit. Okay. Seventh question. Which of the following is a second generation LMA device? LMA is what? Laryngeal mask airway. This question is the repeat question but twisted PYQ. Intubating LMA is a first generation. Procil is a second generation which has a drain tube. Do you remember the picture? Let me show you, okay? Flexible LMA is first generation. Umbo LMA is also first generation. So I told in my previous class that the examples are very, very important. This is the Procil LMA. This was asked in the question, which has a drain tube. Hence, it belongs to second generation. Let me show you the first generation some pictures. This is the LMA Classic, which has only one tube, that is for ventilation. Okay, this is the Ambu Aura 40. So flexible LMA, intubating LMA, Ambu Aura 40 or Ambu LMA and LMA Classic all belongs to first generation. This Ambu Aura Gain belongs to what? Second generation. Okay. Coming to the eighth one, what is the inhalational anesthetic agent used for induction in children? Save the children. Save the children. Give Savo. Sevoflurane, which has a sweet smell. Okay. So children will love it. Sevoflurane is the inhalational anesthetic agent used for induction in the children. Non-pungent, sweet-smelling, alveolar concentration increases, but blood solubility is very low. Hence, fast recovery during the post operation. Desflurane and isoflurane has a pungent smell, hence patient will have a irritation. Okay, causes coughing, breath holding, and laryngospasm. The nitrous oxide, due to its second gas effect, used as a carrier gas for other inhalational agent which is volatile, okay, and not given alone because that is when you administer the anesthetic agent along with nitrous oxide, the nitrous oxide has a ability to rapidly diffuse. Okay, so it will not diffuse alone, it will take the other volatile anesthetic agent along with it, hence it increases the second gas effect. Okay, nitrous oxide accelerates the uptake of second gas and it enhances its anesthetic effect. Okay, this one point you can remember, that is nitrous oxide is not administered alone. So here answer is sevoflurane. Ninth one, the patient was planned for surgery under general anesthesia. During the induction of anesthesia, rocuronium 85 mg was given. The patient was tried to be intubated. It resulted in failed intubation. Which of the following drug can be given immediate to reverse the drug? Okay, now we have to know the rocuronium is already given and tried for intubation, but intubation was unsuccessful. So, which of them can be given immediately? A reversal for rocuronium, that is Sugama Dex. So, let's see other options. Neostigmine is used when to reverse the depolarizing muscular blockade of succinylcholine. When succinylcholine was given in the question instead of rocuronium, then you would have given a neostigmine for a reversal. Okay, glycopyrrolate, our favorite question. It is an anticholinergic drug which decreases the cholinergic effect. Hence, it decreases the side effects of neostigmine. Okay, it is given to decrease the secretions. Okay, androphonium is a short-acting acetylcholinesterase inhibitor preferred in cases of mevacurium reversal. Okay, okay. So Sugama Dex is used to reverse the rocuronium. 10th one, which of the following is incorrect regarding thiopentone? It is a lipid soluble. Yes, correct. Thiopentone is highly lipid soluble, hence it will redistribute very fast, okay, to the adipose tissue, muscles, brain, etc. So it achieves maximum concentration in the brain as soon as you administer, okay. But the rapid decline is due to what? Rapid decline is also due to the redistribution only. Okay, its effect is decreased due to its redistribution, not due to renal excretion. Rapid decline in the effect of thiopentone is due to rapid redistribution out to the tissue like brain, heart, liver, kidney, not due to renal excretion. Okay, that one sentence you should know. Thiopentone is an important drug. Coming to the 11th one, which of the following will lead to decrease in diastolic BP? Okay, let's see. The loss of lumbar sympathetic outflow decreases the diastolic blood pressure. Why? The diastolic blood pressure is primarily depends on vascular tone. We know this, isn't it? The peripheral vascular resistance. So, which is mediated by alpha adrenergic receptor. The loss or blockade of lumbar sympathetic chain, that is when given a spinal anesthesia, the loss of vascular tone or vasodilation occurs. Okay, hence there is pooling of blood in the venous capacitance vessels. Subsequently, decrease in the diastolic blood pressure occurs. Orthostatic hypotension or syncope can occur. This one sentence, lumbar sympathetic outflow blockage is nothing but the spinal anesthesia. Loss of lumbar sympathetic outflow decreases the vascular tone and there is decrease in the peripheral vascular resistance. Okay. Hence, the diastolic BP will decrease. Other options, the smooth muscle relaxant, the example sildenafil does not causes decrease in diastolic BP. Okay. The beta 1 adrenergic agonist causes increase in systolic BP and heart rate. Alpha adrenergic blocker also causes decrease in diastolic BP, but it is minimal. So here the preferred answer is loss of lumbar sympathetic outflow. Okay. This alpha adrenergic blockade also causes decrease in diastolic BP, but more preferred answer is C. Which of the following must be avoided in post cardiac arrest resuscitation care? The mean arterial pressure is kept over 65, correct? Maintain the SpO2 above 94% is revascularization procedure if patient develops ST elevation post resuscitation. Yes, we will do stunting and all, right? Bring the body temperature down below 32 degrees Celsius. Therapeutic hypothermia if unresponsive. No, we have to maintain the temperature at 32 degrees Celsius, okay? Not below that. See, body temperature is maintained between 32 to 36 degrees Celsius at least for 24 hours. Okay, that is nothing but targeted temperature management. It will improve the neurological recovery after cardiac arrest. Other uses is neonatal hypoxic ischemic encephalopathy and stroke patients. We will maintain the temperature at 32 to 36 degrees Celsius. The mean arterial pressure is maintained at more than 65 mm of Hg to prevent ischemic injury and support the organ function. The SpO2 is 92 to 98%. Okay. Revascularization procedure if patient develops ST elevation. Hence, we can't bring below 32 degrees Celsius, but we can maintain at 32 degrees Celsius. Yes. So we are done with the 2024 paper. If you want notes PDF, send a mail. Okay. So I am trying to provide notes. Let us see. If you need, you can mail me. Okay. Happy studying. Take care and revise it. If you are getting something wrong, write it down and revise it again. Okay. From the same book. Revising from the same book is very, very important. Okay.